and I'm going to talk to you today about hyperammonaemia. I would have really liked to make this sort of interactive, and I try to do it interactive, but I'm not sure how well we manage to do this. I don't know, you can probably send me a message, not sure whether I can unmute you somehow and get you to talk. And just to give you a little overview, what I'm going to touch upon today. So I'm going to talk to you about the sort of different clinical presentations of hyperammonaemia, the differential diagnosis, the investigations to reach a diagnosis, and the acute management of hyperammonaemia. And I want to start with a case, just to make it a little bit more clinically relevant as well. So this was a little boy who was born at term. He was born in good condition with a weight of 3.1 kilos. He was the first child to non-consanguineous parents, and there wasn't any significant family history. He had some antibiotics for risk factors for sepsis, and they were discontinued after 48 hours following a negative blood culture. And on day 3, he presented with poor feeding, grunting, respiratory distress. I just have the sort of go-to meeting box all over my slides. So I'm not sure how to, so I can't actually see my whole screen. Anyway, so on day 3, he presented with poor feeding, with grunting, respiratory distress, hypotonia and seizures, and he had 1 dose of phenobarb, which kind of stopped his seizures. And his initial investigations were like a full blood count, user-needs, they were unremarkable, and his CRP was less than 1. His blood gas had a pretty much normal pH, a fairly lowish CO2, 3.5, a normal bicarb of 19, basic excess -4, normal glucose and lactate. And he had an ammonia measured at the time, which was 794, so it was significantly raised. And I would really like to know what you would think would be like the best 3 investigations, or the 3 investigations that you would choose initially from this list of investigations. And I think I'll just give you a little bit of time while I read out the different choices, and maybe make a note or note down what you would say, and then we can go through them later. So what would be useful in this case? Would it be a CSF lactate, a CSF microscopy, a cranial ultrasound, ketones, a urinary toxicology, plasma amino acids, EEG, urine organic acids, liver biopsy, or an MRI brain? So you've probably thought about it by now. So these 3 would be my choice. So these would be ketones, plasma amino acids, and urine organic acids. So well done. Someone actually wrote down the choice. Someone said 5, 6, and 8. So there would be yeah, so quite similar. And just to let you know, so the urinary ketones were 1+. And I will come back to his investigations later, but I thought at this stage, I want to give you a sort of simplified approach to the differential diagnosis of hyperammonaemia and how you can interpret the biochemistry and the various metabolic conditions. So whenever you have a raised ammonia, you can then look at the blood gas and see whether there is any metabolic acidosis present or whether there is no acidosis. And you can then check the ketones, because that will give you further information of which metabolic defect is likely. So if you have prominent ketones and a significant metabolic acidosis, this is more indicative of an organic acidemia. However, if you don't have any ketones present, when you do have metabolic acidosis, you often see these pictures in a fatty acid oxidation defect. If you, on the other hand, don't have a metabolic acidosis, you can then check the plasma amino acids. And this is what you normally see in a urea cycle defect. And they often have a very specific amino acid profile. And then a specific amino acid profile is, for example, seen in citrullinemia or argininaemia. And in another condition where you often don't see any specific changes on the amino acid profile, but you have a high peak of urinary orotic acid and the urine organic acids. Oops, need to go back by one. So you see this quite common then or you see this typically in an OTC deficiency, ornithine transcarbamylase deficiency. And what investigations would you do if you have a raised ammonia? So before you actually have the ammonia, you probably already have the baseline bloods anyway, which would be a full blood count, E's and E's, LFTs, and bone profile for a calcium. You obviously would have a blood gas. Helpful is also a CK, because, for example, in the fatty acid oxidation disorders, you can see a raised CK. The ketones, as they are often significantly raised in the organic acidurias, and then the plasma amino acids, acyl carnitines, and urine organic acids. And in the first case that I was talking about, the progress was that this baby was intubated and ventilated, and loaded with ammonia scavengers, which were sodium benzoate and phenylbutyrate, so the typical medication we normally give for hyperammonaemia, and was also given arginine. I will show you later why we do that in these disorders. And typically they have a loading dose followed by a maintenance dose. And then the baby was urgently transferred over to PICU at Great Ormond Street. And there he received hemofiltration in order to reduce the ammonia, because the ammonia is very toxic to the brain, and in order to prevent any long-term neurological sequelae, it really needs to be urgently managed to get the level down very quickly. And you can see here his ammonia level over time. So he initially presented to the local hospital when his ammonia was just below 800. And by the time he reached Great Ormond Street, you can see that it had risen even above 1,000. And this was when hemofiltration was started. And you can see that the hemofiltration led to a significant drop in the ammonia, actually within 24 hours. And we were able to stop hemofiltration the following day. And just to go back to this baby's investigation. So a couple of days later, unfortunately, we don't get these metabolic investigations back straight away, but a couple of days later, we saw his plasma amino acids, and there was a significant raise in glutamine, arginine, ornithine, and a low citrulline. And in the urine was a high orotic acid. So if we now, I can't give you a metabolic talk without showing you some biochemistry. So we just want to remember the urea cycle. And in the mitochondria, the toxic ammonia is metabolized to carbamoyl phosphate, which is then further metabolized to citrulline. And to do that, we have an enzyme here that's called OTC, so that's the ornithine transcarbamylase. And the ammonia is then, and that's further metabolized in the cytosol, in the urea cycle, to urea, and the urea can then, that's obviously non-toxic and can then be excreted in the urine. And if you look at the pattern of this baby, so this baby had a high arginine and ornithine, but this is probably only because, you know, we've given this baby arginine, so of course that would be high. You can also see a high glutamine, because anytime that you have a raised ammonia, it is metabolized with glutamate to build glutamine. And you can also see a very low citrulline and a high orotic acid in the urine. And that's a typical picture that you see in OTC deficiency. So when you have a defect in this enzyme. And OTC deficiency is one of the commonest urea cycle defects. You may remember that it's inherited in an X-linked fashion. So we normally see very severe phenotypes in males. And the females, they can often be asymptomatic, but they can also manifest as heterozygotes at any age and with any severity. And the treatment for this urea cycle defect is with a protein-restricted diet. We give them ammonia scavengers and arginine, and I'm going to come back to the treatment a little bit later. And the causative treatment would be a liver transplantation. So the urea cycle enzymes, they're all only expressed in the liver. So whenever you give these patients a new liver, you replace the enzyme. So it's like an enzyme replacement therapy at the same time. That was the choice for the little baby that I presented to you now. So he's currently on a waiting list for a liver transplant. I want to go through another case. So this was yet another baby, a male Asian infant who was born to consanguineous parents. He was born a little bit early at 36 weeks with a birth weight of 2.3 kilos and had an emergency cesarean for failure to progress. He was born in a quite good condition with his ABGAs were 8 and 9, and he was initially well. However, on day 2, he developed poor feeding and was subsequently transferred to SCABU. On day 3, however, he became more unwell. So he had feeding difficulties, he was jaundiced, was jittery, and had significant weight loss, so more than we would expect. He started to have apneas and then also had a reduced conscious level with a GCS, but yeah, with a reduced GCS. So again, in this case, what would be your initial investigations? And initially we can just think general pediatrics, not just metabolic. You can have a, I don't know, couple of minutes septic workup, perfect. So Habab agrees, so it's obviously a query sepsis, and we would do, I'm sure all of us would send a full blood count, CRP and blood cultures. And what would be useful is next investigation. So as we've gone through already before, we would do an ammonia. Yeah, perfect. It was a blood sugar check. So the blood sugar would obviously be on the blood gas as well. The blood gas will also give us a lactate, electrolytes. It's useful to look at the liver function, so to see what the transaminases are doing, and check ketones. So, and in this case, the blood gas was the following. So had a significant metabolic acidosis with a pH of 7.0, a low bicarb of 12, a base excess of -14, a lactate of 3.7, a glucose of 2.4, so a low sugar as well, and then sort of normal electrolytes. And if you maybe remember the anion gap, you can calculate from a blood gas. I'll come back to how you calculate that later. And the anion gap was 30. So as a sort of rough cutoff, anything that's above 20 is abnormal. And his ammonia was 360. So that's also significantly raised. And in the urine, he had 3 places of ketones. His calcium was a little bit on the low side with 1.9. And on a full blood count, he had neutropenia. So to summarize this, so he had a severe metabolic acidosis, moderate hyperammonaemia, a high anion gap and ketosis, which are really the typical findings for organic acidemia. So I just want to remind you again about the anion gap, because it's a really useful thing to do when you have a blood gas, to look at the anion gap. So you calculate the anion gap as sodium and potassium minus chloride and bicarb. And normally you see anything in the range between 8 to 16. And anytime that it is elevated, it suggests that there's extra acid. And that could be either ketones present or lactate or any other organic acids, as you see in the organic acidurias. And if it's normal, it's more suggestive that this is probably a renal problem, like a renal tubulopathy, or a GI problem, for example, significant vomiting, diarrhea, etc. Okay, and next you can think about this question again in regards to management. So what would be the three things top on the list that you would do? Again, you can have a little bit of time to think about it. If you want, you can chat to me and just write down what you would do. So your choices are, you could either stop feeds and give 10% dextrose IV. You could stop the feeds and give 5% dextrose. You could start the little one on chlorpromazine. You could give mannitol. You could start them on IV sodium benzoate. You could go for hemofiltration, start TPN, give dexamethasone, or load with phenytoin. So we've got a few. I've got a few answers already. So definitely 3 people now think definitely to stop feeds and start on 10% dextrose. And the other ones would be, so Heber says start IV sodium benzoate. And Habab says to also go with phenytoin and hemofiltration. So in this case, I would definitely stop the feeds and give 10% dextrose. Start on IV sodium benzoate in order to control the ammonia, and think about hemofiltration very early on, because the hemofiltration won't just treat the ammonia, but also any sort of additional acid that's present. The baby hasn't had any seizures yet, so I think then you'd probably go for phenobarb anyway. What other choices did you give? I think otherwise we were all on the same anyway. Oh yeah, and Jung said to start on TPN, but we hold off TPN for now because the TPN obviously has protein in it. And initially we don't want to give any protein, but I'll come back to that. So obviously, as always, a couple of days later, we did get the metabolic investigations back. And in the urine, we had a peak of methylmalonic acid, as well as in the plasma. The acyl carnitines, they showed a raised propionyl carnitine. So this is the typical finding that you have in methylmalonic acidemia. And just to show you where the defect is, so if from the breakdown of branched chain amino acids, you first get propionyl CoA that is metabolized to methylmalonyl CoA, and this is then by the methylmalonyl CoA mutase further metabolized. And this enzyme also needs a cofactor, vitamin B12. So this is why some of the MMA cases are actually responsive to vitamin B12 supplementation. And what are the organic acidurias? So the most common ones, the ones that you probably have heard before, are what we said already, the methylmalonic acidemia, MMA. So with an incidence of about 1 in 50,000. Propionic acidemia, a little bit rarer, 1 in 100,000, and isovaleric acidemia. And the IVA is one that we screen for in the newborn screening on day 5. And to make a definitive diagnosis, we need to do the urine organic acids, acyl carnitines, and plasma amino acids. However, it's really important that we don't wait for a diagnosis because, as I said already, it takes a couple of days for them to come back. We need to treat before. And what's the emergency treatment for the organic acidemias? So first we would stop any protein because we want to reduce the sort of load on the pathway, and give generous calories, so in order to promote the anabolism. We would normally treat the acidosis quite aggressively with sodium bicarb, and we consider hemofiltration, so as I said already, for treatment of hyperammonaemia as well as the metabolic acidosis. And in the organic acidemias, we normally give a medication that's called L-carnitine. So carnitine binds the sort of additional acids, and they are then less toxic and they can be excreted. And to promote anabolism, we give 10% dextrose. So the main thing with all the metabolic patients is that they're usually started on 10% dextrose in the fluids. So you would just give that with the normal electrolytes, with 0.9% saline and potassium. And then you can also consider an insulin sliding scale to promote anabolism. And whenever these children are on the insulin sliding scale, so if they do go hypo, you just want to give them more glucose and not stop the insulin. And when do we actually, there's always the question, when do we decide what is actually hyperammonaemia? So in the neonatal period, we usually get concerned if the ammonia is anything above 150. While after the neonatal period, anything above 50 is abnormal. And the treatment of hyperammonaemia, I've already mentioned that is an emergency because you want to prevent any neurological damage. So we always have to start treatment before the cause is actually known. But of course, we would send off, whenever possible, the investigations before we actually start treating. And why is that? So the ammonia is very neurotoxic and it causes very rapid permanent neurologic damage. And it is because the ammonia causes, also if you have got a raised ammonia, it causes glutamine accumulation in your astrocytes, which then leads to astrocyte swelling and cerebral edema and can even lead to brainstem compression. And it also causes astrocyte dysfunction, which in the end leads to an encephalopathy. And the sort of neurological damage really depends on the time that the hyperammonaemia is present and the peak level. So you really want to control it very quickly and get the ammonia down as soon as possible. And the treatment of hyperammonaemia can be conservative with ammonia scavengers. These are typically sodium benzoate and sodium phenylbutyrate. And I'll come back how to prescribe them in the next slide. And the other treatment for high ammonia is, as I've mentioned before already, hemofiltration or dialysis. And this is usually considered if the ammonia is above 400 and if there's no response to the pharmacological treatment within 4 to 6 hours. So that's why we usually ask that we repeat the ammonia quite frequently to see whether it goes up or down, we can make a decision which way we're heading. And this is what it looks like on PICU when these little ones have the hemofiltration. And the conservative treatment of hyperammonaemia, so the medications you give, are this ammonia scavengers, which are sodium benzoate and sodium phenylbutyrate. And for both of them, the dose is the same. And they require a loading dose that we give over 90 minutes with a dose of 250 milligrams per kilo. And this is then followed by a maintenance dose over 24 hours. So that's 250 milligrams per kilo over 24 hours. And you may sometimes get a message from us that we can increase the dose to a maximum dose of 500 and 600 milligrams per kilo, respectively. And you can see that it gives a significant sodium load when you give it IV, and obviously we need to monitor the electrolytes. Whenever we suspect a urea cycle defect, we also give arginine. So if you remember from a previous slide, so the arginine is within the urea cycle. And if we give additional arginine, it just replenishes the urea cycle. So it just sort of makes it work better. And as in an emergency, we also give carnitine if we consider that it's a organic acidemia. So particularly if you've got like a significant metabolic acidosis and ketosis. And we give that usually at 100 milligrams per kilo per day. And in an emergency, we give that intravenous. So it can be either by bolus or continuous infusion. And the only time when we're hesitant to give carnitine is when we suspect that it's a fatty acid oxidation disorder, because in these disorders it can cause arrhythmia. So then we would hold it off. And I just want to point you towards a really useful homepage if you haven't come across it yet. So there's a British Inherited Metabolic Disease Group, and they've got an amazing homepage with loads of different guidelines. So you can find it on bmdt.org.uk. And on the emergency guides, you can find the guidelines for all sort of metabolic investigations. And it also gives you access to a drug calculator. So you can actually I'll show you that now. So the drug calculator, for example, hyperammonaemia, you can see it there. It comes up as an Excel spreadsheet. And you can put in the patient's weight, and it will automatically calculate the doses for those 4 emergency drugs that I've given you, for benzoate, phenylbutyrate, arginine, and carnitine. And it calculates as 250 milligrams per kilo for the loading dose and the maintenance dose. And if you needed to change the dose, so if we say, well, start baby on whatever 500 milligrams per kilo per day of maintenance, you can put it in here into the green box, and it will again calculate for you how you have to make up this infusion. And it's usually made up with 10% glucose, because the more glucose the better anyway. And you make it up in a 50 ml syringe usually. And there's just a question from someone called S, whoever that is, whether the maximum dose excludes the loading dose. So you don't consider the loading dose at all when you give the maintenance dose. You just give the loading dose, and then the 500 milligrams per kilo or 250 to 500 milligrams per kilo per day of maintenance dose, completely independent of the loading dose. I hope that this answers your question. Yeah? And what's the differential diagnosis for hyperammonaemia? So we've already gone through the urea cycle defects and the organic acidemias. Then we do sometimes also see raised ammonia and fatty acid oxidation defects, but it's not that typical. You can obviously see it in severe liver failure. So as I said already, the urea cycle and the urea cycle enzymes, they're only expressed in the liver. So when your liver doesn't work, then obviously your urea cycle can't work either. So in liver failure, you then also get a raised ammonia. You also see it in transient hyperammonaemia of the neonate. So when the ductus venosus is open, the ammonia is actually shunted across the liver and can't be metabolized. So you can initially see a raised ammonia until the ductus venosus closes. You also see a raised ammonia when you've got increased muscle activity. So for example, in a post-ictal state, you do sometimes see an ammonia that goes up to like 200. And also drugs can interact with the urea cycle, such as valproate, just like the typical drug can give you a raised ammonia, but also chemotherapeutic agents, so there's like vincristine or asparaginase, can cause raised ammonia. But probably the most common cause for sort of falsely elevated ammonia is a sampling error. Just to remind us how to take an ammonia, so it really needs to be a free-flowing venous sample, definitely not a heel prick. And we need to make sure that the sample is taken to the lab immediately after taking the sample and on ice. And obviously we're often asked, when should we consider a metabolic defect or a metabolic disorder? And typically babies that have an inherited disorder of metabolism, they have an initial symptom-free interval. So if you've seen for the first 2 cases, so they had like the first couple of days, they were completely fine, and they only started to become unwell on sort of day 3, or often it's like within the first week then, so day 3 to day 5, that they become unwell. Obviously, because most of these disorders are autosomal recessive disorders, so it's helpful to take a family history and ask about consanguinity, because we see these disorders more often in consanguineous families. And it can be really helpful to take a good family history, because sometimes you then find out about previous unexplained neonatal deaths that may be due to metabolic disorder. And what we find is that they often deteriorate despite the sort of symptomatic therapy. So often it's like a septic baby that just doesn't improve. Sorry, I've just overlooked the question from Joshua. And he's asking, with valproate therapy, what is an acceptable ammonia level? So we're discussing that all the time, and we never quite know what we should do with a patient who's got like ammonia level of 100 or 120 and is on valproate, but we'll probably reduce the dose. So I think it should be within the normal level, but you would obviously also consider whether the patient has any neurological symptoms, so whether he's in any way lethargic, etc. So I think you always need to interpret the result sort of together with the clinical picture. Sorry, go back to this slide now. But yeah, in general, there is this sort of typical presentation of metabolic disorders, but the issue is that it's not a highly suggestive presentation, and often they are quite unspecific, and they can also be associated and triggered by infection. So hence, it's sometimes not so straightforward to decide when a presentation is metabolic or not. But I think the important thing is just to remember to do the appropriate investigations and keep them safe by giving them, for example, 10% dextrose. And in general, for a sort of neonatal presentation of the organic acidemias and urea cycle defects, as I said already as a summary, so they're initially well, and they present more towards the end of the first week of life, or like after 2 to 3 days. And very common is that they are lethargic and feed poorly. Often they vomit, they are dehydrated, and they can develop tachypnea. Tachypnea for 2 reasons. So as to compensate, for example, for a metabolic acidosis, but also the ammonia itself is a respiratory stimulant, and hence you can have a respiratory alkalosis with a high ammonia, but I'll still come back to that as well. And then they typically develop into an encephalopathy plus minus neurological signs. So they're often quite hypotonic, and they can develop seizures. Sometimes loss of reflexes, and develop apnea. And some of these conditions have a very characteristic smell. So initially I was always wondering what do they smell like, but for example, then we did have a baby who had IVA, so isovaleric acidemia, and in the textbook it says that they smell of sweaty feet, and indeed they do. So once you get an untreated baby, they can have a very characteristic smell. But to complicate things, organic acidemias and urea cycle defects can present in older children as well. So they can present as acute encephalopathy. They can present very unspecific with failure to thrive. And often it's really sort of important to take a good diet history, because some of these patients, they naturally develop an aversion to protein. So for example, with the later diagnosed urea cycle defects, really when they're often on a vegetarian diet and they can't stand meat. Well, we should always feel for a liver anyway, but particularly if you consider any metabolic disorders, feel whether they've got a big liver, because many do. And they can also present with relay symptoms and acute liver failure. They can develop mental retardation or developmental delay. Neurological symptoms are often ataxia, hypotonia, or a movement disorder, and here particularly dystonia. And they can have neurodevelopmental regression, so it's important to take a proper developmental history as well. And they can have seizures and psychiatric symptoms, which I've almost forgotten. And I just want to give you another sort of case history. So this was a 9-year-old girl who was completely fit and well until she was 9 years old, so no concerns until then. And at 9 years of age, she presented with increasing abdominal pain, with an unsteady gait, and changing behavior. So she became more emotional and was crying a lot. And then she was admitted acutely with vomiting, with drowsiness and increasing encephalopathy. And she had a respiratory alkalosis, so she had a pH of 7.48, and the CO2 was around 2.5. And she had mild liver dysfunction. So alarm bells here already ring. So an ammonia was obviously done, and her ammonia was 480. And we obviously did her plasma amino acids, and she had a low citrulline, a normal ornithine, but in the urine organic acid, she had a peak of orotic acid. So this is just repeating the biochemistry of the first case we've already heard. So this is the typical kind of pattern of OTC deficiency. And she was again started on a low protein diet, ammonia scavengers and arginine. And sometimes we can't even, just by looking at the biochemistry, differentiate between the organic acidemias and urea cycle defects when the patients behave like in the textbook. Because with the organic acidemias, as I said already, so they develop a metabolic acidosis. They often have very significant weight loss. They develop hypocalcemia, often have neutropenia because the organic acids are also toxic to the bone marrow and lead to bone marrow suppression. And the hyperammonaemia is usually not as bad as in the urea cycle defects. And the urea cycle defects, so typically they present with a respiratory alkalosis. So as I said already, the ammonia is a respiratory stimulant, and hence can lead to a respiratory alkalosis. However, if then the child becomes very sick, can then also develop a metabolic acidosis, so it's not written in stone. And the weight loss usually in urea cycle defects isn't as significant as in organic acidemias. But what's important about the urea cycle defect, so the hyperammonaemia is very significant and the ammonia is very high and usually is rapidly increasing. So hence we ask you to recheck the ammonia after a couple of hours or 4 hours you've done the first ammonia level. So what I want you to take away from this talk today is really remember to do an ammonia. So whenever you see a sick neonate or a child who is like lethargic or kind of looks like isn't developing an encephalopathy, just do the ammonia and take it correctly. Do a venous sample, get it to the lab on ice. It seems like a lot of bother initially, but it's so much better than having to do it all again and then sort of not knowing where you are. And remember that hyperammonaemia is an emergency, so you really want to prevent the long-term neurological damage. And remember that whenever you look at the blood gas, that you can calculate the anion gap, because it's so useful in interpreting whether you're truly dealing with a metabolic problem or whether you should call, instead of the metabolic team, call the renal team or the gastro team. So whenever the anion gap is raised, so that should ring the alarm bells and you should pick up a phone and give us a call. And remember that the fluids for sort of most of the metabolic patients, so there are a few exceptions, but is 10% dextrose with added electrolytes. And I would urge you all to have a look at the BMDG homepage. So it's incredibly useful. It doesn't matter whether you are just dealing with a patient with hypoglycemia or a patient with I don't know, hyperammonaemia. There are a lot of guidelines there, and also there are specific guidelines for each, well, for most of the metabolic disorders that you come across in A&E, and also it shows you there the emergency plans for the different metabolic conditions. And whenever you have any questions, so we're happy to receive any phone call and discuss any patients that you want to go through. So with that, I want to thank you for listening. If you have any questions after this talk, you can always send me an email, but otherwise you can just type your questions now, or I don't know whether I'll be able to unmute you so we can have a chat. Okay, well, I hope it was useful to all of you. Ah, you're saying, okay, one question is some cases of hyperammonaemia worsen with arginine. Why? So it depends on where the metabolic block is. So if you remember the urea cycle, it can sort of, I mean, we do think that it's safe in most of the urea cycle defects, but if you have a defect that where the sort of overload with arginine may present a problem, then we don't give arginine every single condition. But in general, because one of the sort of most scary ones that we deal with is the OTC deficiency, arginine is actually quite safe. So in an emergency situation, you can definitely give arginine. And is there a, okay, next question is there a target ammonia level where we can alter the benzoate? Or can we do it based on symptoms of the child? So we do obviously consider both the symptoms of the child and the ammonia level, but normally, so for example, if you start them on ammonia scavengers, you would always want the ammonia to normalize before you then switch them, for example, before you, for example, reduce the ammonia dose or switch them to enteral, not ammonia dose, the benzoate or phenylbutyrate. So you would wait until the ammonia normalizes and then you make changes. So which means that it's usually less than 50. Then we would think about changing benzoate or butyrate, like reducing it and then changing it to enteral again. So we wouldn't just base it on the symptoms, we definitely check the biochemistry and check the ammonia. So if the patient with hyperammonaemia treated early, still there's a risk of CNS affection. So yeah, from the literature, we know that sort of children or babies that have an ammonia above 1,000, that's usually associated with neurological sequelae. But even lower levels than that can cause neurological damage. So really you want to sort of catch it as early as possible and treat it as early as possible. Okay. I don't know whether there are any further questions. Okay, all right. Well then, thanks for listening. Yeah. Okay.